going to evaluate is the first compartment, which contains the abductor pallucis longus and the extensor pallucis brevis. And then next to the first compartment is the second compartment. So in the second compartment, we are going to find two tendons. One is the extensor carpi radialis longus, the other is the extensor carpi radialis brevis. And the honor to the second compartment is the third compartment. So in the third compartment, we expect to see the extensor pallucis longus. And next to the third compartment is the fourth compartment. So in the first compartment, there are two groups of tendons. So one is the extensor indicis proprius, and the other one is the extensor digitorum communis. So on top of the distal radial ulnar joint is another tendon. The tendon is very small, which is the extensor digiti minimi. And the one on top of the distal ulnar is the extensor carpi annalis. So if you want to have a better image of the dorsal extensor tendons, it's better to start at the level of the distal radius. So on the distal radius, there are several bony structures that we have to familiar with. First, of course, is the distal radius, and then the anatomical structure separating the tendon inside the second and the third compartment, which is the distal tubercle. And of course, the other one is the ulnar. So besides the dorsal aspect of the wrist, another thing that we are interested in is at the volar wrist. So at the volar wrist, I think the structure that we commonly refer to is the carpal tunnel. So outside of carpal tunnel, you can expect to see some structures. For example, dermis, subcutaneous fat tissue, and then another one is the tendon of the flexor carpi radialis. This tendon is outside of the carpal tunnel. And another one is the ulnar artery, and the ulnar nerve is inside the cubital tunnel. It's between the palmar carpal ligament and the flexor retinaculum. And the flexor retinaculum serves as the floor of the carpal tunnel. And inside the carpal tunnel, we expect to see median nerve, and the flexor pallucis longus tendon, and the flexor digitorum superficialis, and the flexor digitorum profundus. And another important thing is what are the bony structures that serve as the border of the carpal tunnel. At the most radial side, we can find the scaphoid, and at the floor, we can find the capitate and the hamate. At the most ulnar side is the peace bone. So we know the benefit of ultrasound is its capability of dynamic examination. So in many cases, we use static ultrasound when we cannot find any abnormalities. But if we use dynamic ultrasound, maybe we can find something wrong. So we know the most common pathology of the wrist area is decrever. But there are some pathology mimic the decrever disease. For example, it's the proximal intersection syndrome. So where is the proximal intersection? Proximal intersection is the area where the tendon inside the first compartment crossing the tendon over the second compartment. So in this case, you can find between the tendon inside the first compartment and the tendon inside the second compartment, there is the thickening of the tendon sheath with hypervascularity. So the patient has a proximal intersection syndrome. And another area where a patient can have a symptom like decrever is the distal intersection area. So where is the distal intersection? Distal intersection is the area where the tendon inside the third compartment, which is the extensor pallucis longus, crossing over the tendon inside the second compartment, including the extensor carpi radialis longus and the extensor carpi radialis brevis. So in this case, again, you can find the increased vascularity between two groups of tendons. So it indicates the patient has distal intersection syndrome. So the benefit of ultrasound is allow us for dynamic examination. So we can use ultrasound to see the association between, for example, the extensor pollicis longus and the tendon inside the second compartment. So another thing is, another tendon that can have a problem is the extensor carpi annalis. So as you can see, extensor carpi annalis is situated on top of the distal ulnar and the insert on the distal carpal bone. So there are some structures that stabilize the extensor carpi annalis, including the dorsal extensor retinaculum and the substrate at the deeper area. So we can ask a patient to perform the radial and ulnar deviation to see if there is any dynamic instability. So we can let a patient place the wrist over the bottle containing the ultrasound gel and ask a patient to do the ulnar and the radial deviation to see the extensor carpi annalis gliding over the distal ulnar. So in patients with instability, we can find, once we ask a patient to deviate the wrist to the ulnar aspect, we can find the extensor carpi annalis move outside the groove over the distal ulnar. So it indicates the patient has extensor carpi annalis subluxation. So just like I mentioned before, the most prevalent pathology over the wrist region is the decreval tenosynovitis, which involve the tendon inside the first compartment. So if we use ultrasound to examine this area, the most common variant that lead to the decreval disease is the multiple tendon slit. And the tendon component that have multiple slit is usually from the abductor pollicis longus, because the size of abductor pollicis longus is bigger than the extensor pollicis brevis. You can imagine, in such a small area, if there are multiple tendons inside, it's going to increase the intracompartmental pressure and increase the risk of the tenosynovitis. So besides the multiple tendon slit, sometimes we can find a secant retinaculum. So we can ask the patient to have a dorsiflex and molar flex of the thumb, and then sometimes we can find that the tendon is entrapped by the thickened retinaculum. And another variant is the septum. So the septum will separate the abductor pollicis longus and the extensor pollicis brevis. So if you want to know how the tendon arrangement, you can use dynamic examination. For example, in this case, you can find the case has a multiple tendon slit and also have an effusion surrounding the tendon. So you may question, because the tendon is located at a very superficial area, why should we use ultrasound to evaluate? I'm going to show you a case. So as you can see, this case, this is the normal site. Usually the size of abductor pollicis longus is bigger than the extensor pollicis brevis. But in this case, you can find there is a septum separating the tendon of abductor pollicis longus and the extensor pollicis brevis. Actually, the patient received palpation-guided injection but failed. So the reason is because I think the injector probably went to the wrong compartment. So later we use ultrasound guidance to let the injector go to the compartment containing extensor pollicis brevis, and then the patient had completely pain relief. So this is another case. So the case also had tenosynovitis of the first compartment. So you can see the tendon was swollen. So we gave the patient ultrasound guided injection, and then after that you can find that the tendon becomes less swollen. But after that, the patient still have pain over the dorsal aspect of the thumb. So we thought the patient might have some nerve entrapment. So we gave the patient additional superficial radial nerve block, and then after that, the patient had totally pain relief. So very interestingly, when we examine the patient, we also find the patient had a stamping thumb. So if we ask the patient to dorsi and the volar flex the thumb, we can find that the extensor pollicis brevis had abrupt movement against the AB duct hallucis longus. So later we gave the patient dynamic ultrasound guidance to the first compartment. So after late, the tendon become less swollen, but the patient still had some neuropathic symptom. So finally, we gave the patient ultrasound-guided superficial radial nerve block, and after later, the patient said her symptom was totally gone. So regarding the volar wrist, I think another common pathology is the trigger thumb or trigger finger. So in patients with trigger finger, we can use ultrasound to evaluate. We can ask the patient to flex and extend the finger to see what is the structure that causes the snapping or causes the entrapment of the finger flexor tendon. So here you can find the reason why the patient has a trigger finger is due to thickened A1 pulley. So besides using ultrasound to see tendinopathy, we can also use ultrasound to evaluate whether the tendon is ruptured or not. So this case is he practiced martial arts. So one day he found that he had a difficulty to extend the thumb. As you can see in the ultrasound image, you can find the extensor pollicis brevis is partially ruptured. So that is the cause of that's the cause why the patient cannot extend his thumb. So we know besides the tendon, there were also several nerves. So the nerve can cause some problem. For example, at the radial side, the nerve related to the first compartment is the superficial radial nerve. But regarding the other side, the nerve related to extensor carpi annalis is the dorsal ulnar cutaneous nerve. So here, in this case, you can find the case complaint of ulnar wrist pain, and then we use ultrasound to evaluate. So here you can find the retinaculum was thickened as well as the tendon of the extensor carpi annalis. But if you pay more attention to the structure besides the retinaculum, you can find there is a swollen hypoechoic bubble beside it. This is the dorsal ulnar cutaneous nerve. If you compare with the nerve at the contralateral side, you are going to find the nerve at the pathologic side was much swollen. So in the long SSB, we can clearly identify the nerve was entrapped by the two segments of the thickened extensor retinaculum. So besides using ultrasound to evaluate the integrity of the tendon, to evaluate the nerve beside it, sometimes we can find some normal variant. For example, in our case report, you can find at the first compartment there is a hypoechoic structure in the first compartment. So was this a tumor? No, it was not a tumor because you can find a similar structure at the contralateral side. Actually, this is the aberrant muscle. The name of the muscle is the extensor digitorum brevis annus. And if you encounter patients with distal radius fracture, and then you find the patient has difficulty to extend the thumb, what are you going to do? You may arrange ultrasound examination for this patient. So in this case, you can clearly identify at the fracture site, there is the bony segment, and the bony segment actually impinge the extensor pollicis longus. So if you want to let the motion of the extensor pollicis longus to recover, you definitely need to remove the bony segment, bony fragment. So because the wrist and the hand are very superficial, so I think many doctors, when you perform injection, you usually use palpation guidance. But in this case, the case complained of dorsal wrist pain. And she came to our clinic presenting with difficulty to extend her thumb. We asked why. Because that when she had dorsal wrist pain, she went to the local clinic to receive corticosteroid palpation guided injection. After 2 weeks of injection, the patient had difficulty to extend the thumb. So we use ultrasound to evaluate. So at the dorsal aspect of the wrist, you can find that this is the area where the extensor pallucis longus should be located. But in the pathological side, you barely find any tendon fibers in comparison with that of the normal side. So if we move our transducer to the more cranial part, we can identify this area is where the muscle of the extensor pallucis longus should be located. But in this case, you can find that the muscle become atrophic. So use ultrasound image, we are able to know what happened to this patient. The patient received steroid injection, and unfortunately, the steroid was administered to the tendon itself. So it caused rupture of the extensor pallucis longus. So in this case, probably you have to differentiate whether the patient has some nerve problem. For example, the entrapment of the posterior interosseous nerve. But if you find the echogenicity of other muscle remain normal, you know this is not a problem of the neuropathy. It's actually the problem of the ruptured tendon. So that's what this story told us. We can use ultrasound to evaluate what happens in patients with difficult motion of the wrist and hand, and also we have to use ultrasound guidance to inject the wrist and the hand tendons.
1
So,
minute left.
Finally, let's have a summary of today's talk. Regarding the 6 dorsal compartments, the most prevalent one is the equilibrium disease. And for extensive cardiac pathology, we know it could have instability. And for extensor pallucis longus, a tendon come to have a rupture if you have adverse palpation guided injection. And for the lower wrist stenosis synovitis, you can use dynamic ultrasound to evaluate. So if you are interested in my talk, you are welcome to join MSK Ultrasound Club on Facebook. Thank you very much.